Good afternoon, everybody. I'm recovering from surgery as we speak. Welcome to this afternoon's lecture on diseases that affect the integumentary system. For those of you who don't recall, the integumentary system is the outer covering of the body. It's the largest organ in the body by weight, and it functions in fluid homeostasis, thermoregulation, defense from pathogens. It is a first barrier against disease, and it also functions in vitamin D synthesis. We'll touch on each of these skin functions in detail in the video that's coming up on the normal function of the human skin. So with that said, what are we going to talk about today? What are we going to talk about today? We'll explain the functions of the skin, and we'll recognize some common lesions. We'll describe how seborrheic dermatitis affects the skin, and we'll discuss the common causes of contact dermatitis, atopic dermatitis, and psoriasis. We'll describe the treatment of acne vulgaris. We'll explain the pathologic course of herpes zoster. We'll name the etiology of impetigo, and we'll explain why the treatment of cellulitis is important, and cite examples of classifications of fungal infections of the skin. We'll list preventative measures for decubitus ulcers, and we'll name the two most common parasitic insects to infest man. We'll describe how infestation can occur. We'll name two common pre-malignant tumors. We'll differentiate the three types of skin cancer. We'll describe the guidelines for avoiding excessive sun exposure and list some of the conditions that are caused by the abnormal development or distribution of melanocytes. For those of you who don't remember, melanocytes are those cells in the skin that produce the dark pigment that shields us from the damaging effect of the use of the sun's UV radiation, which causes DNA mutations. We'll name some possible causes of alopecia. If anybody remembers alopecia, that's male pattern baldness. We'll state the cause of warts, and we'll list some of the likely causes of deformed or discolored nails. Okay, so if you think about the skin, this is really your first line of defense against disease, because the skin provides a waterproof barrier that, as we stated, provides a hostile environment for pathogens. It produces secretions that don't allow fungi or bacteria to thrive for a significant period of time. And we also want to make note of the fact that the skin is shed with great regularity, so that even if pathogens do happen to find themselves on the integument, they are generally rapidly removed due to the fact that the skin replaces itself at a rapid rate. Remember that the deeper layers of the skin, the epidermal layer called the stratum basale, gives rise to the differentiated upper layers of skin. And probably if you've had me for ANP2, you remember me telling you that 99% of dust is actually human skin. So think about that the next time you dust your home. The skin is also involved in thermoregulation. It's vascularized at the dermal layer. We'll see these layers of skin in a moment. And when the body wishes to cool itself, it'll increase capillary permeability, and it'll vasodilate, which will bring blood to the surface of the skin, just below the epidermis, and the heat will be radiated off. What happens is that the energy carried in the blood in the form of heat energy is lost as kinetic energy as we warm the air that's close to our bodies. In addition to that, you all know that when it's hot outside, you sweat, at least I hope you do, and the sweat cools the body through evaporation. The transition of water from a liquid state to a gaseous state carries away kinetic energy from the body, and the result is a cooler skin surface. And with the vasodilation that we see when we're in a hot room, for instance, the combination of that and the evaporative cooling serves to bring our body temperature back down to within that normal range, which cycles around 37 degrees centigrade. Other organs we want to be aware of: the skin contains hair follicles and hair shafts. It also contains sebaceous glands and sudiferous glands. The sudiferous glands are the sweat glands, and the sebaceous glands are the oil glands. And I can't stress this enough, a barrier between you and the outside world. It also aids in water balance, for the same reason that it aids in thermoregulation, because we can lose excess water through either cutaneous transpiration that we're not aware of, sweat that we don't actually see, or through actual sweat that pools on the skin surface. Okay, so what are some of the skin's accessory organs? Hair, nails, glands, the layers of skin, which we'll get into in a moment, the dermis, the epidermis, and the subcutaneous layer. So let's take a peek at each of these. This is a cross-section of normal skin. And what I want you to notice here is that the upper layer of skin is constantly regenerated and shed. This area here that I'm indicating with the pointer is the stratum basale, and this is what regenerates the upper skin layers at a rapid rate. We would say that the stratum basale is an adult stem cell population that exhibits a high mitotic index. What does that mean? It means that the cells in this layer divide rapidly, and they quickly differentiate into the flattened squamous cell type that we associate with the epidermal layer. This entire block here from the stratum basale towards the superficial aspect is termed the stratum germinativum, the basale and the spinosum, and the upper layer here is the stratum granulosum. These cells are already dead. They've lost their nuclei, they've lost a significant component of their cytoplasm, and they essentially serve as a shield. We also want to notice these different layers of skin: the epidermis, as we've been talking about, the dermal layer, which is heavily vascularized and contains smooth muscle, which enables us to cause the hair on our skin to either stand up or lay down. This is another method by which the body can thermoregulate itself. If you want to think about the way raising hairs on your body can keep you warm, think about a down jacket. And if you have a winter jacket at home, it's usually filled with a stuffing such as holofill or feathers or even down in some cases. And what that does is it produces a layer of dead air between your body and the outside environment. And these hairs actually serve a similar purpose. When you go into a cold room, you're probably familiar with the phenomena of getting goosebumps. And what's happening there is that these muscles, these smooth muscles, which are called erector pili muscles, will tug on the hair shaft and hair follicle and cause the hair to stand more erect, and this produces a layer of dead air between you and the outside environment if you find yourselves in a cold room. There's also a lot of nerve endings in the dermal layer. And why are these important? Well, because they are part of our general sensory apparatus, and they give us an indication of what's going on in our environment. For instance, we're able to tell hot, cold, tickle, pressure, touch, and probably most importantly pain as a result of the sensory nerve endings that you find peppered throughout the dermal layer. If we didn't have these, we'd be less able to manipulate our environment and put ourselves in a situation that would enhance our survival. We talked about one very astonishing incidence of this, which is the disease known as Hansen's disease, which goes by another name. You probably know it from the Bible as leprosy. And what happens in leprosy is that a pathogen named Mycobacterium leprae will actually infect the nerve endings and disrupt the pain-sensing apparatus in the skin. And so what happens in these individuals is they accumulate puncture wounds and lacerations and such, and since they're not receiving a pain signal as a result of the inflammation that sets in following a wound, they don't treat the wound, and the wound can become infected, become gangrenous, and then those layers of skin can actually rot and fall off. This is actually a secondary outcome of the infection. So this is why you probably are familiar with scenes from antiquity depicting lepers as missing fingers, toes, the ends of their nose, and so forth. It's all because the pain apparatus isn't doing its proper job. We actually have a treatment for this now, and it's thalidomide, which first hit the market as a morning sickness drug, and it turned out that it was actually a teratogen, which is a chemical that causes birth defects, and the specific birth defect associated with thalidomide was flipper-limbed children, where the long bones, the humerus, the radius, and the ulna don't fully develop, and so you essentially have hands and wrists fused directly to a very shortened humerus, even if there even is one that articulates directly with the glenoid fossa of the scapula. So you just have these little hands coming straight out of the shoulders. And so the drug was quickly taken off the market after they were able to link this birth defect to that particular compound, but it's come back on the market because it's a potent treatment against leprosy, and it's prescribed for men and for postmenopausal women for obvious reasons. Okay, we also want to notice the hair follicle around the hair shaft. These are the cells that give rise to the hair shaft, which is made up primarily of keratin, which is basically dead extracellular matrix material. It's protein. We also want to make note of the subcutaneous fat, which serves as both an energy store and a form of insulation for the body. And you want to take note of the dermal papillae, which protrude into the epidermal layer, and what these serve as on your fingers and your soles of your feet and your toes. These are the source of your fingerprints and your toe prints and so forth. So these are where the ridges come from. So they're more pronounced in certain portions of the body than others. Okay, so the layer that gives skin its strength and its elasticity is the dermis, this layer here, which is a dense fibrous layer of connective tissue. And we talked about previously when we were discussing connective tissue, and we were discussing the roles of vitamins in human physiology. Vitamin C and its role in collagen synthesis. This is one of the reasons that you want to have vitamin C meet the RDA in your diet regularly, because without adequate vitamin C, connective tissue such as collagen isn't properly synthesized, and this can lead to a disorder called scurvy. And we discussed the fact that back in the bad old days, when it was difficult to staff a ship that was going to set sail on the trade routes, one of the things that they would do is take the local alcoholics out for a drink, and they would wake up the next morning not in their home but on board ship. They had been drafted, and they would often set sail with nothing but preserved meats, hardtack to eat, and this is obviously not a balanced diet, and it was lacking in, among other things, vitamin C. And so what would happen is a lot of these crew members would become sick. They would tend to bleed, the wounds wouldn't heal properly, and they'd suffer all kinds of maladies. So one of the solutions was to get an onboard source of vitamin C, and that was citrus fruits, and this is the source of the term limey, if you've ever heard it, or scurvy knave, if you've ever watched pirate movies. It references the fact that in order to supplement their vitamin C needs, they needed to have limes as part of their diet. Okay, so what we want to do now is take a peek at this video that's going to talk about the normal functioning of skin. So sit back and I will rejoin you when the video's over. So at this point, Georgina, you can go ahead and run the skin video. So go ahead and pause this portion of the lecture and open up the real-time video regarding the human skin. Okay, hopefully that was a nice review of the normal functioning of the integumentary system and the importance of treating it right and all the wonderful things it does for the human body. So let's talk about some common skin condition symptoms. Cutaneous lesions or eruptions. Cutaneous means of or pertaining to the skin. I also want to talk about pruritus, which is the clinical term for itching. Pain, which, as we've already discussed, is an important indicator of a condition that needs to be treated. Without the pain signal, we wouldn't treat injuries when they occur, and the possibility for infection and exacerbation of that particular injury would exist. Edema, which is the clinical term for swelling, and erythema, which is the clinical term for redness of the skin, often caused by inflammation produced by capillary congestion, and also inflammation itself, which is characterized by edema and erythema and pain. Which symptoms need attention from healthcare professionals? All of these listed. The condition that is known to be an aggravating factor in each of these particular symptoms is stress. Many skin conditions are diagnosed by the appearance of these conditions, of these particular symptoms. They can be indicators of other disease states, and so they're often used as an early diagnostic tool for physicians in order to ascertain other problems that the individual might be suffering. So let's talk about a few common skin lesions. A macule is a small lesion of a different skin color than normal skin, while a plaque is a large elevated lesion with a surface. A cyst is basically an enclosed pocket that contains fluid, and it's often the result of something like an ingrown hair. A pustule is a small circumscribed elevation of the skin, and it can often contain purulent fluid that's indication of an infection. A scale is a small, thin, dry lamina that's shed from the skin. A burrow is a passage or a gallery formed under the skin by the wandering of a parasite, and this is often accompanied by pruritus. A papule is a small, firm, elevated lesion, while a nodule is simply an elevated lesion. A vesicle is an elevated lesion that contains clear fluid, and a crust is a dry, rough surface or dried exudate that contains fluid, cells, or cellular debris that has oozed into the tissue because of injury or swelling. This is basically the outcome of the body's battle against whatever is causing that particular condition, and it's a byproduct of inflammation and wound healing. A fissure is a small deep crack or tear in the skin, and a comedo is more commonly known as a blackhead. So here's a few of these particular skin lesions. You can see in the upper left hand corner the appearance of a macule. Upper right hand corner how a papule looks. Lower left hand corner a plaque, and lower right hand corner a nodule. So the thing to note here is which layers of the skin are involved, and notice that the macule is entirely contained in the epidermal layer, while a papule will involve both the dermal and the epidermal layer. Basically, you can see the elevated marking here, and notice that when we're talking about the dermal layer, we're talking about this pink layer with these papilla-like protrusions into the epidermis, and the epidermal layer is this upper tan looking layer. A plaque involves primarily the epidermal layer, while a nodule can also involve the dermal and the epidermal layers together. Note the differences between a macule and a papule. A macule is a small, flat, circumscribed lesion of different color than the rest of the skin. and a papule is a small, firm, elevated lesion. Here you can see a few more skin lesions. Note the pustule in the upper left, the cyst in the upper right, the crust in the lower left, and vesicles and bulla in the lower right. What is the difference between a cyst and a blister, which would be indicated by these vesicles or bulla? And that the difference is that a cyst is a nodule that's filled with either liquid or semi-solid material, and it's slow forming, whereas a blister is an elevated thin-walled lesion containing clear fluid and generally has a rapid onset. Anyone who's ever burned themselves on an oven or as a result of getting scalding liquid on their skin will exhibit blisters and bulla as a result of incidents of this type. Whereas a cyst is more of a long-term proposition, and it's often due to, as I stated earlier, conditions such as ingrown hairs. And what happens is that this semi-solid material will form as a result of this particular accessory gland being redirected outwardly or inwardly as opposed to outwardly. And there's also accompanying inflammation, usually when you're referring to a cyst, as there are with these vesicles and bulla. Okay, some more skin lesions. Here you can see scales, fissures, burrows, and comedos. The skin lesion that's caused by a burrowing organism is obviously a burrow. Generally these are insects, and what they're doing by burrowing is they're trying to find an area to feed off of the tissue as well as lay eggs. And obviously this is going to be extremely annoying. You're going to exhibit inflammation and pruritus with these types of vectors. They carry disease over and above what they do to the skin. So this is one of the reasons that we want to concern ourselves with insect-borne diseases, not just because of the direct damage that they do to the skin, but also the diseases that they carry. Notice that the burrows go subepidermally. Sometimes they can reach into the dermis. Scales are limited to the epidermal region, while fissures are really dependent on the type of condition that produces it. They could be limited to the epidermal layer, or they could go all the way to the dermis, while comedos or blackheads generally involve the epidermal layer, and they tend to be a function of sebaceous glands, which become infected with certain types of bacteria, such as Acne vulgaris. So with that said, let's go into a little bit more depth on skin lesions. We have a quick video here, so take a listen.
Hello, my name's Adrian Richards and I'm the Surgical Director of Aurora Clinics. And today I'm going to be talking a little bit about skin lesions and the different types of skin lesions. Well, essentially, all of us have some moles, and the average number of moles an individual has is approximately 7. And moles and skin lesions can come in all sorts of different forms. But the essential, the two main groups are either non-malignant, which is the vast majority of lesions, or cancerous lesions. So if I first deal with the non-cancerous lesions, the majority of these are moles. So when we're sort of in our teens, early 20s, we tend to get flat, brown moles, and as we get slightly older we get more domed moles. So these sort of almost look like little pearls in the skin, and they tend to sort of slowly grow in size, and these are called intradermal nevi, which are basically slightly deeper moles. So the most common type of non-cancerous skin conditions are moles, either pigmented, brown, flat moles, or nodular moles. And then as we get slightly older we can get sunspots, area of thickened skin, which is called seborrheic keratosis, or areas of sun-damaged skin, which are called actinic keratoses. So there's a number of different types of benign skin lesions, and all of these can be removed relatively simply under local anaesthetic, and often it's quite a good idea to come and have a consultation just to talk about the best way of removing these, because it's easier to remove them when they're smaller, and obviously this leaves less scarring. The other main group is the cancerous or precancerous skin conditions, and I will talk about these in another video. But essentially, if you're worried about any mole, you need to come in and see us, or see a specialist. And the main real symptoms of concern are change, and these are the four main things: change in colour, so this is pigmentation becoming darker normally; change in surface, so if it was a flat mole and it's become more irritated and raised; change in the size, so that's the contour, has it changed size, has it grown in one direction, and the other main change is symptoms, so if it suddenly starts itching or you feel it slightly different. So if you've got a long-standing mole that does any of these characteristics, it changes in any way, normally best to come in and just get it checked out, because again, if it is a skin cancer or an early skin cancer, if we can get at the mole early and remove it before it has time to spread, that's best for everybody. So I hope that's made some sense. Obviously there's a vast number of different types of skin lesions, but the majority are benign, so be reassured, the majority are completely non-cancerous and can be dealt with relatively simply. So thank you for listening to this video. If you'd like to make a consultation with any of our surgeons to have your skin assessed and to talk about possibly removing any moles, please let us know, either by phoning us on 01844 214 362 or emailing us via the Aurora Clinics website, which is aurora, aurora-clinics.co.uk, or again by emailing us or phoning us. So thanks very much for listening. I hope you enjoyed the video. Hello, my name's Adrian Richards, and I'm going to be talking today a little bit about skin lesions and some of the factors that, if you do have them, should perhaps be causing you concern and may warrant an appointment with one of our specialists. So the first thing to say is moles and skin lesions are really common, and everyone's got them, and the average person has approximately 7 moles on their body. Some people obviously much more moly and other people less. So most skin cancers do not develop in pre-existing moles, but some can. So it's worthwhile keeping an eye on the moles you have, see if they change, but really any new moles we need to know about. So most moles tend to grow very slowly. So there are 2 main different types of moles: intradermal nevi, which are sort of dome-shaped moles on the face, which are normally slightly pinky colour but not dark. And the main form of skin cancer that's most worrying is a melanoma, and this is a skin cancer of the pigment containing cells in the skin, and these are the melanocytes. These are the cells that, when stimulated by the sun, cause you to tan, and a melanoma is a tumour of the melanocytes. So basically, if you notice any new mole arising which is growing, sign of concern. If you notice any change in an existing mole or a mole that's recently appeared, so that's change in the surface, if it becomes rougher or changes or becomes scabby, any change in colour, particularly if it becomes darker. And one of the things we watch out for is mixed pigmentation. So if one area of the mole is light, one area is dark, that can show us that one area has got an excess number of melanocytes producing the pigment. And change in shape is another area of concern. If one area of the mole starts growing, and the other point is change in symptoms. So if you get itching, bleeding, or you're more aware of the mole, those are factors which really we need you to come in. So Overall, most moles are absolutely fine. If, however, you are worried in any way, and particularly if you feel if any mole is recently changing, altering in any way, please come and see us. And if you know, most cases we'll be able to reassure you, or just do a biopsy and take a specimen of the mole, and that will be the end of it. Occasionally we will find a skin cancer, but if you have got a skin cancer, please come and see us earlier rather than later, because it's much easier to deal with a relatively small lesion before it's spread than slightly later. So I hope that's been informative. If you'd like any more information, or you're worried about any skin lesion, please contact us either by ringing us on 01844 214 362 or contacting us via the Aurora Clinic's website. Thank you very much.
Okay, some more common diseases of the skin include dermatitis, and anytime you see the suffix itis, think inflammation of. So this is inflammation of the skin. Seborrheic dermatitis is an inflammation of the sebaceous glands, while contact dermatitis is caused generally by coming into contact with an agent that produces this type of inflammatory response. Atopic dermatitis or eczema is an inflammatory condition of the skin, and it's characterized by redness, itching, and oozing vesicular lesions. These can become scaly, crusted, or hardened. While psoriasis is a chronic skin disease characterized by circumscribed red patches covered with white scales. So basically, dermatitis is an inflammation of the sebaceous glands. These are your oil glands in your skin. Heredity plays a role in eczema. It's thought to be an inherited allergic condition. What is the relationship between psoriasis and plaque? Well, they develop in psoriatic patients under physical trauma. So if you have an individual who is suffering from psoriasis and you have a region of the skin that is under physical stress, either rubbing or pressure or stretching, they can develop plaque very easily. So both of these types of conditions, eczema and psoriasis, are immune malfunctions, and essentially they're hypersensitivity reactions. There is thought to be in some of these conditions, such as eczema, an autoimmune component where what's happening is that the body may be rejecting certain exudates or certain tissues that are present in the dermal or epidermal layer. Often anti-inflammatories and immune suppressants are prescribed for people that have an extremely severe case of these particular conditions. Other diseases of the skin, let's go and expand a little bit further on dermatitis. We're going to note the difference between seborrheic dermatitis and contact dermatitis. Seborrheic dermatitis is an idiopathic condition resulting in overproduction of sebum. Okay, so let's pause for a moment here and note that funny word, idiopathic. If anybody knows what it means, I'll give you a couple of seconds and you can shout it out. And in case we didn't get an answer, the answer is it's clinical terminology for we don't know what causes the condition. So an idiopathic condition resulting in overproduction of sebum. Remember that sebum is basically the oil that is produced by the sebaceous glands. Cradle cap is one of the manifestations of this particular type of dermatitis. Infants suffer from this, and it can be caused by a diet that contains food with substances to which the infant is allergic. Contact dermatitis is localized redness and swelling caused by an irritant or an allergen. And so this tends to be much more restricted in the amount of body surface area that it covers, and the major challenge in contact dermatitis is to identify the allergen. And once we do that, we can take steps to eliminate contact with it, or we can prescribe drugs to minimize the effects. So let's take a little listen to dermatitis.
It sounds like you might be a good candidate to try an antifungal treatment. Basically, the steroid creams take care of the symptoms of itching and flaking, but they don't treat the cause. Although we don't know for sure, seborrheic dermatitis might be associated with a fungus. Watch out for an infection, either bacterial or viral, which could make it worse and less responsive to steroid creams. You might need antibiotics in that case. You are right to be concerned about long-term UV light treatment. Use that treatment only when necessary, maybe for bad breakouts or when you have to look your best. There are stronger medications called immunomodulators, but these are only recommended when everything else has failed, since the side effects could be quite severe.
From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Good morning. This morning I want to talk a few minutes about allergic contact dermatitis. First, let me explain. You see, the name itself says a lot. Allergic contact dermatitis. Basically, you see a lot of erythema and edema. Patients come with itching, and that is followed by vesicles and bulla, and many times you see these things as crusty lesions or scaly lesions. Now, let us start with definitions. What is contact dermatitis? Contact dermatitis is basically, it results from the direct skin contact with chemicals or allergens. 80% of cases due to excessive exposure to, anything like it could be a soap, it could be a detergent, it could be an organic solvent or a hair dye or a shampoo, and they can all cause irritant contact dermatitis. And you see the redness and the scaliness, and then they're becoming vesicular. The most common cases of allergic contact dermatitis are poison ivy, poison oak. Remember that, because you will see this so many times. And then there is bacitracin and neomycin, the topical antibiotics, topical anesthetics like benzocaine, and sometimes preservatives can cause irritant contact dermatitis. Sometimes jewelry like nickel. Some patients take vitamin E and use all kinds of these alternative medications. Even regular cosmetics can cause this problem. So they finally cause some kind of weepiness to these lesions, and finally these patients come to you with the rash. And the characteristic rash, if you see in the initial stage, you will see tiny vesicles, small vesicles. And these tiny vesicles, they become like crusty with time. And when the things come repeatedly, like people who are having a chronic form, then they will have this thickened skin below that crusty form. So the crusty lesions and developing over that thick skin, that happens in a lot of patients, and exposed parts, wherever their skin is exposed to the irritant, they will develop that. And you will see vesicles, bulla or plaque and over that skin. Now you can see that swelling and excoriation and crusting, a lot of places, and there won't be any distribution also, like a symmetric distribution. I mean, you will see the asymmetric distribution in many areas, and the distribution can give you a great clue. For example, take poison ivy. You will see the linear streaks of vesicles. Sometimes patients would tell you this is like lines of vesicles, lines of these water bubble like lesions. So when you see those linear streaks of vesicles, you don't need anything. You're seeing poison ivy. So very important point, folks. And when you, even the location, like for example, face, think of like any cosmetics or creams and soaps or detergents. Like hair, think of any shampoos patient is using, or hair dye products. Some allergy on the nails, think of nail polish, or neck dermatitis, think of any jewelry like allergy to nickel. Many people will have that allergy to nickel. So you see, folks, the location it gives you a great clue to the diagnosis and the cause, and you can tell patients to avoid those causes. And many times even secondary infection happens. When secondary infection happens, you need to do the gram stain and culture to identify the bacteria. So you will treat even bacterial infection. So you have to treat the contact dermatitis and also the bacterial infection. Two things are going on when secondary infection happens. So how do you treat this? The number one thing is prevention. Never forget that. Many times patients come with contact dermatitis. We throw some corticosteroid ointment or prednisone tablets, and we don't worry about prevention. That's very important. Prevention. You need to tell to the patient to avoid whatever is causing that problem. So a good history is important, and from that good history, if you see the specific cause, you need to educate the patient to prevent it. Then the local treatment. For example, if the rash is on the hand, you need to use a topical steroid. Many times the lesions become weepy. At that time, we have to wrap it around so that that weepiness of the lesion does not interfere with the patient's lifestyle. So irritant contact dermatitis is basically treated with the protection from the irritant and also topical corticosteroids. So those are the local measures. So if you see acute weeping dermatitis, use compression bandage around that part. And don't scrub it. Many people, when they see this weepy lesions, they will take a soap and scrub it and they make it worse. So you should not scrub it. You should just use compression bandings when they are oozing. And also when there are lesions on the extremities, you can use dressings, and the dressings have to be changed many times. You can use calamine lotion to hydrate that particular dried part of the skin. Then some lesions which are very severe needs high steroids like clobetasol, halobetasol. These high dose corticosteroids, they help suppress acute contact dermatitis, which are very severe, because patients will have that itching. They say that I want to cut down this spot, it is so itching. In those times, you should not use mild corticosteroids. You should go for high dose corticosteroids. And then when you are using high dose corticosteroids, you should have a plan of tapering it. Like for example, if you start with clobetasol, you need to taper it to a mid-potency steroid like triamcinolone. So you taper it slowly to prevent that rebound dermatitis. What happens if you do not do that? Rebound dermatitis happens. The other thing is systemic corticosteroids. You can start with prednisone, like 60 milligrams first 1 week, then 40 milligrams next 1 week, then 20 milligrams next 1 week. Thus, you give steroids like 14 to 21 days. The other way to do is to give like 5 milligrams tablets, telling the patient to take 12 tablets on day 1, then 11 on day 2, then 10 day 3, then 9 day 4. Like that you cut down. That is easy for the patient to follow. So you need to use high dose corticosteroids when the acute dermatitis is severe. I mean, many doctors prescribe Medrol dose pack, which is not a good idea. Yeah.
This patient here, we did a crane operator physical on him yesterday.
Okay.
And on his physical, he passed his hearing test and his vision without glasses. Do you remember if he had a hearing aid or not?
Oh, no.
No? So I can cross these off that you checked? Okay.
You can do that.
All right, thank you.
Thank you. So Medrol dose pack is not a good idea. I mean, you can write down Medrol dose pack, use as directed, simple, but Medrol dose pack is not strong enough, is not long enough. Those are the two things. Medrol dose packs, they are not strong enough, they are not long enough to treat these symptoms, folks. So you need to write down a strong prednisone dose, like 60 for first week, 40 second week, 20 third week, like that. So those are the most important points I wanted to share with you this morning about allergic contact dermatitis. As always, visit my website drpaul.org, and thank you very much.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.
Okay, a couple more conditions of the skin before we break. Let's talk a little bit about acne vulgaris. It's an inflammatory disease of the sebaceous glands and hair follicles. We can treat it with topicals or systemic antibiotics, as well as keratolytic agents, which are substances that cause the skin to shed. And as we'll see in a moment, some of these compounds are extremely powerful. The symptoms of this condition are papules, pustules, and comedos. The age group most susceptible is teenagers, and the precautions that should be taken when using one of the most potent keratolytic agents called isotretinoin is psychological side effects that the patient may experience, such as depression, psychosis, and even thoughts of suicide. This compound is administered under an FDA program called iPledge. Providers, this includes physicians, nurse practitioners, and pharmacists, have to participate in this particular program. It's basically like a controlled substance. Okay, herpes zoster is an acute inflammatory dermatomal eruption of painful vesicles. The groups most susceptible are children and individuals over 50 years of age. This is one of those viral diseases that stays with you for the rest of your life if you've contracted the condition in childhood. And the reason for this is that the virus, which is the pathological agent, likes to live inside the dorsal root ganglia. Remember that those are the peripheral nerves that exit the dorsal margin of the spinal cord, and they carry to the spinal cord our sensory information, but they serve in this case as a safe house for the virus while it lies dormant in a condition called latency. Certain conditions such as stress can awaken the virus from this dormant state, and it'll then begin active assembly of virus particles, which will then erupt through the peripheral nerves and cause these lesions on the skin. In childhood, this is chicken pox, and in adults, this condition is characterized as shingles. And they tend to, in the adult, be limited to the thoracic region. And how is it that we treat the condition? Well, it's mainly palliative, because the virus is going to go latent at some point after being reactivated due to whatever stress condition caused it to erupt forth. But until then, we just have to deal with the pruritus to avoid scarring and infection. So there are a lot of topicals that can serve as an effective treatment for that particular aspect of the condition. Urticaria are hives. They're characterized by severe itching followed by an appearance of redness and an area of swelling known as a wheal. With that said, let's go on break for 15 minutes. So Georgina, let them go out, get something to eat or drink, have them back here in 15, and we'll finish up the back half of the lecture. Okay, hope you had a good break. Let's talk about chickenpox a little more. It's a precursor to shingles. It's generally contracted in childhood. Chickenpox and shingles are both caused by the herpes varicella zoster virus. This is a DNA virus. The symptoms of shingles are a band-like unilateral pattern along the course of the peripheral nerves or dermatomes that are affected and don't cross the midline of the body. Pain, often in the form of burning or tingling, begins about 2 or 3 days before the appearance of the lesions and sometimes is accompanied by a fever. The eruptions begin as a rash that rapidly develop into vesicles. The skin that overlies the affected dermatome or dermatomes becomes reddened and blistered, and the vesicles are often grouped on a reddened area of the skin. After several days, the vesicles appear pustular and they develop a crust and then begin to scab. So what do we do about this? We're in the throes of shingles or chickenpox. The treatment is directed towards making the patient comfortable. Analgesics, mild tranquilizers or sedatives, as well as antipyretics. What do you think an antipyretic is? I'll give you 5 seconds. And those would be anti-itch medications. Also, steroids can be used. Examples are methylprednisone, prednisone, and bechamethasone. You can also utilize a drying agent applied directly to the vesicles. There are antiviral drugs such as acyclovir, which can be used orally, parenterally, or topically. Also, other antiviral agents that may be useful include famciclovir, valciclovir, or foscovir. Antibiotic therapy may be necessary to prevent a secondary infection. If the eye is affected, early treatment with idoxuridine is necessary, and an ophthalmologist should supervise this therapy. When the pain is intolerable, injections of lidocaine and nerve blocks may be attempted. If these steps don't provide relief, permanent nerve blocks through alcohol or nerve resection may be a last resort. Shingles occasionally recurs at later dates. Remember that the virus never leaves you. It simply takes a nap inside those dorsal root ganglia. So this is one of the reasons that you see advertisements for shingles vaccine for individuals in their advancing years, because the idea is that the immune system can fail to keep the virus in check, and so it's going to need a little bit of a booster in the form of a vaccination, and this can serve to keep the manifestation of shingles at bay. So let's take a little listen to chickenpox and shingles.
Post-herpetic neuralgia, in contrast to diabetic neuropathy, most commonly manifests as mononeuropathy, meaning the condition affects a single nerve root. The herpes zoster virus causes chickenpox, but also remains dormant in the body's dorsal root ganglion cells once chickenpox has subsided. The herpes zoster virus can reactivate at some later point, causing shingles. Why the herpes zoster virus reactivates in a specific person is rarely understood. However, known causes include immune system depression and other CNS conditions, including stress, hormonal changes, or nerve injury. When herpes zoster reactivates, it inflames dorsal root ganglion and infiltrates dorsal root neurons. This inflammation hinders dorsal horn cellular metabolism. In particular, it impairs nerve conduction and pain transmission. The herpes zoster also targets the peripheral segment of the dorsal root ganglion. The virus travels from the dorsal root ganglion to peripheral nerves, causing shingles' characteristic rash. Once in the peripheral nerves, herpes zoster can cause peripheral demyelination and fibrosis.
Okay. Impetigo is a contagious superficial skin infection. The lesions are most likely found on the legs and less often on the face, trunk, and arms. 3 of the common causes are strep or staph, and the infection is thought to originate from insect bites, scabies infestation, poor hygiene, anemia, and malnutrition and impairment in the skin integrity that can often be related to eczema. How do bacteria responsible for our next condition, cellulitis, most often enter the skin, usually through a small cut or lesion? Cellulitis is an acute diffuse bacterial infection of the skin and the subcutaneous tissue. In both these types of diseases, it's important to pay attention to proper hand washing technique. Good washing is essential for prevention. Attention to small nicks and cuts helps prevent the infection. So again, keeping it clean and keeping it disinfected are going to go a long way in lessening the amount of time an individual suffers with this particular condition. So let's take a listen to Impetigo.
Roper St. Francis Healthcare's House Calls TV.
Impetigo is a contagious skin infection, especially common in children because it's often spread at daycare or school. Dr. Valerie Scott describes impetigo.
It'll start as a red bump or a little blister, and then it'll start to spread, and you'll see the top of it looks like honey colored crust. It'll be very crusty and maybe a little bit red. Your child won't have a fever, will basically be healthy, but the infection will continue to spread if they scratch it.
Impetigo comes from bacteria like strep or staph and can be treated.
What you can do is clean the area. You can soak the child's scab and remove it. I would probably wear gloves while doing that so that you don't get it yourself. If the crust keeps coming back or it spreads, you really do need to go see your doctor. The doctor will either treat you with a topical antibiotic that's by prescription or an oral antibiotic, depending on how widespread the infection has become.
For more information, call 402-CARE. For House Calls TV, I'm Merritt Dempsey.
Roper St. Francis Healthcare's House Calls TV.
Hi, I'm Dr. Enoch Choi of medhelp.org, and I wanted to share some helpful tips on how to manage cellulitis, a skin infection that sometimes requires antibiotics. The main thing to remember with a skin infection is that you need to keep that area of your body that's infected elevated over the level of your heart. The reason why that is that it helps drain the infection away, allows your body to be able to attack the infection with its white blood cells, the cells used to attack infection, and it helps deliver the antibiotics better because that area isn't so swollen, and the blood supply can deliver the medication that you're taking. It's important to remember that if you get a high fever, if you have shortness of breath, if you have any worsening before you're getting rechecked, it's something that you need to talk to your doctor about and consider being seen for. It's pretty hard to work when you have a skin infection like this, since you need to keep the area of infection above your heart, so you probably won't be able to work. You know, it's something that is hard enough to do that oftentimes you'll need to probably stay on the couch or just be resting with that part of your body, if it's an arm or a leg or whichever part of your body, elevated above the level of your heart. And you want to do that all the time, probably for at least for the next couple days. You probably can't do your regular work that way. You want to keep if there's a wound, if there's an opening in your skin, you want to keep that clean and dry, but you can take showers. You want to change bandages over this area every day, and if you have been told by your doctor to do so, you can use some polysporin to try and prevent any local infection of the opening, and also keep the dressing from sticking. That makes it a lot more comfortable to take the bandage off. Oftentimes your doctor will ask you to come back for a recheck. If so, you should probably go and do that. And sometimes that's something that's done on a daily basis, especially if you need another dose of IV antibiotics, which some people need if the infection is serious enough. Now, how are you supposed to manage just lying on the couch all day? Well, you can take bathroom breaks. Try, make sure you can take a short walk, like for 10 minutes, say, 3 times a day, and ask somebody to help you, or you may need a cane or a walker to do that. And when you're not on that walk, keep that area elevated. I haven't told you enough times now, you have to keep it elevated over the level of your heart. That'll let the swelling go down. If you get the area wet with a shower, make sure you pat it dry after washing it. Put a clean dressing, a bandage, or Band-Aid on it after you wash. Whether or not you're showering, you can change that every day. Try and put something warm on that area, on the red part, every day, say 4 times a day for about 10 minutes each time, and that can help deliver more of your blood flow to the area. And make sure that you don't put anything restrictive, any tight clothing above the area that is infected, because you don't want to block blood flow to the area. These are some helpful tips, and of course you need to ask your doctor about specific instructions, but they're helpful hints for dealing with a skin infection called cellulitis.
Okay. Dermatophytoses are chronic superficial fungal infections of the skin. Tinea capitis are lesions on the scalp caused by fungus. Tinea corporis are lesions that are round, ringed, and scaled caused by a fungus that affects tissue on the body surface. Tinea unguenum affects the toenails. Tinea pedis, also known as athlete's foot, is characterized by intense burning and stinging pruritus between the toes and the soles of the feet. Tinea cruris, or jock itch, is characterized by raised red pruritic vesicular patches in the groin area. So these are all diseases that are superficial fungal infections of the skin. The factor that determines the type of dermaphytosis is the region that they inhabit on the person's body. Contact with cats can spread ringworm, so you can think of cats as a vector for this particular disease in humans. Antifungal medications are prescribed either for topical applications in the form of ointments or for oral use depending on the severity of the infection. The agents usually prescribed for treatment are known as Tinea capitis, uses primarily Nizoral shampoo, Tinea pedis, Tinea corporis, and Tinea cruris use Lamisil, Lotrimin Ultra, and Grisofulfin. The affected skin must be kept as clean and dry as possible, and clothing should be loose-fitting and clean, and exercise should be limited to prevent excessive perspiration. Because all forms of dermatophytoses tend to be persistent and chronic, meticulous management is needed to correct this condition. Okay, some other diseases of the skin include decubitus ulcers, which are localized areas of dead skin. These are the result of increased pressure in particular parts of the body. You see these in patients that have an inability to move themselves. Scabies are infestation by parasitic insects known as itch mites, and pediculus are infestation by lice. These are wingless parasites and they feed on human blood. The way that these bed sores, these decubitus ulcers set up, is that we cut off circulation to the areas of the integument that are under pressure by the body weight. And so what happens when you cut off circulation is that you cease blood flow to the tissue, and the tissue begins to die. And the danger here is that you'll eventually generate an open sore that can go all the way to the bone, and this leaves the patient open for sepsis and bone infection, which are very dangerous conditions indeed. This is one of the things that contributed to the death of Christopher Reeve. The parts of the body that are typically affected by lice are the scalp, the pubic region, and the body surfaces. Itch mites and lice are spread by direct or indirect contact. These are very contagious conditions, and these are small insects that make their home on the hair shafts on the body or on the skin. They lay their eggs by adhering them to the hair shafts. These are called nits. And so they're a very challenging condition to get rid of, because you can get rid of the insects themselves, but the eggs, since they adhere to the hair shafts, are difficult to remove. They need to be combed out, and if you don't comb them all out, they'll hatch, and you'll get another round of infestation by these particular pathogens. So let's take a little listen to decubitus ulcer.
A decubitus ulcer, also known as a bed sore or pressure ulcer, is an area of skin and tissue that becomes injured or broken down. When a person is in a sitting or lying position for too long without shifting his or her weight, the constant pressure against the tissue causes a decreased blood supply to that area. Without a blood supply, the affected tissue dies. The most common places for pressure ulcers are over bony prominences, such as the elbow, heels, hips, ankles, shoulders, back, and the back of the head. There are 4 stages for classifying pressure ulcers. Stage 1. A reddened area on the skin that, when pressed, is non-blanchable. This indicates that a pressure ulcer is starting to develop. Stage 2. The skin blisters or forms an open sore. The area around the sore may be red and irritated. Stage 3. The skin breakdown now looks like a crater, indicating there is damage to the tissue below the skin. Stage 4. The pressure ulcer has become so deep that there is damage to the muscle and bone, and sometimes tendons and joints. Treatment begins by relieving pressure to the affected area. Pillows, special foam cushions, and sheepskin are used to help reduce the pressure. Treatment also usually includes rinsing with a salt water to remove loose, dead tissue and covering with a special gauze dressing made for pressure ulcers. It is important to avoid further trauma or friction because infection may occur, which can lead to serious systemic problems.
Okay. Species that infest the head and body include Pediculus humanus capitis. These are head lice. Pediculus humanus corporis, which are lice that infest the body. Diphtherius pubis, pubic lice. These infest the hair and the pubic region. And Sarcoptes scabiei, which are itch mites. And the pictures of them are shown on this particular slide. Those are the head lice. Those are the body lice, those are the crabs, and those are the itch mites. Notice that they're insects. You can tell by the presence of an exoskeleton, an external hard shell, and the fact that they have 6 legs. Those are 2 very easy ways to identify an insect from, say, something like an arachnid, which would be a spider. These are all highly contagious conditions. They're transmitted by direct or indirect contact with infested persons or their clothing or their possessions. all of these conditions have itching as one of their primary symptoms, pruritus. They also exhibit rash and a sensation of something crawling on the skin. The treatments include shampoos and soaps designed to kill the parasites, along with removal of insects and their nits with a fine-tooth comb. In addition, decontamination of the environment through surface cleaning of furniture, clothing, and possessions will eventually clear the infestation from the patient and from the area. And the danger, of course, with not sterilizing or disposing of the clothing or the possessions is that the lice can live on those things for a long period of time after the initial infested person is free of the condition. And if somebody touches or puts on those items of clothing or touches those possessions, they can become infested. So it's very, very easy to spread. So let's take a listen to scabies.
Hello, I'm Dr. Rob Hicks and I'm a GP working in London. Scabies is a very contagious skin infection which causes intense itching all over the body. It occurs when the scabies mite burrows into the skin, eating its way into the skin. It then in the burrow lays eggs which hatch, and of course when these hatch the new mites perpetuate the infection. Scabies is actually very common. It's more common in children and in women. It's more common that people get it from schools and those living in nursing homes because it's close proximity, close prolonged physical contact is how people catch scabies. It also tends to occur in the wintertime, again because people are spending more time indoors in close proximity with each other. But I think it's very important to highlight that it's not related, or there's no scientific evidence relating it to poor living conditions or poor personal hygiene. Scabies, the mite will infect anybody, it doesn't mind. Now, how people get the scabies infection is through prolonged close physical contact. The mite can't jump and it can't fly. So we're talking about things like prolonged hand-holding, sexual intercourse, sharing a bed with somebody, for example. Now, thinking of the symptoms of scabies infection, obviously it's intensely itchy. People just can't settle and they're often clawing at their skin. This itch is worse at night and certainly after a hot bath or shower. And often you find red blotchy marks on the skin and the little lines where the mite has burrowed into the skin. Now all these things help the doctor diagnose scabies. If somebody says they've got intensely itchy skin where they can't get relief, you think, haha, could be scabies. Examine the skin and you may see the red blotchy marks and the thin lines, particularly in the warmer areas of the skin, and that's where the mites like to be. So in skin creases, between the fingers, under the nails, for example. And then if somebody says that somebody else within the household also has very itchy skin, then that adds weight to the probable diagnosis of a scabies infection. Now, it's good that treatment of scabies is relatively straightforward. We recommend using a cream that's put all over the body that contains an insecticide that kills the mite, and it's recommended that this treatment is repeated 7 days later so that any eggs that have hatched in the meantime also get killed by the insecticide treatment. Very important also that somebody's given a treatment to relieve the itching, a cream or maybe an antihistamine tablet, which may also help them sleep at night and get a decent night's sleep so they're not feeling tired the next day. Also very important that other members of the household are treated or sexual partners are treated, even if they haven't got symptoms, to reduce the risk of the person becoming infected again. Good idea to boil wash household linen, clothing, bed linen and towels to make sure that any mites that have survived on these articles are killed, and boil wash more than 50 degrees centigrade. What's very important is that scabies is a very common infection, easily treated, and people shouldn't be embarrassed about asking for advice about it. And they can get this advice from their local genito-urinary medicine clinic or sexual health clinic, certainly from their GP or their practice nurse, or they can pop into their local pharmacy and ask their pharmacist for advice.
For more information, visit www.nhs.uk.
Lice. The word alone is enough to make your head itch, and like it or not, all children are at risk of getting lice no matter how good their hygiene is. Let's go to Mayo Clinic to find out the best ways to get rid of head lice if your kids bring the bugs home from school.
All right, honey, we have to just check for any nits again.
Head lice. The nasty bugs invaded Rosemary Person's house after one of her kids brought some home from a birthday party.
The eggs look like little ants, but smaller.
And boy, do they itch.
I kept scratching my head.
Plus, they're hard to get rid of, especially if you're like Rosemary, whose 4 kids all had lice at the same time. First, she smothered their hair with over-the-counter pesticide lotion. Then, the real work began.
Spent hours and hours combing out all the nits. Literally that entire week, I think all I did was laundry and comb out hair. And I vacuumed all the rugs, every piece of furniture, every day.
You need to do what I call triple vacuuming.
Dr. Dawn Davis says lice have survived since antiquity. They're mentioned in the Bible, and they've also been found on the bodies of mummies. Lice have lasted so long because they've been able to adapt and become resistant to treatments.
There's a lot of resistance in the community because the louse has outsmarted our pharmacology.
So what products should you use? Dr. Davis says the most common treatments are over-the-counter lotion and cream pesticides. But she suggests talking to your doctor because if lice are a big problem in your area, you may want to get a prescription for something stronger. So if your child brings home the bugs, don't panic. With a little hard work and lots of patience, you'll eventually get rid of them. Dr. Davis says you also need to wash all your clothes and put things like stuffed animals in airtight containers for 2 weeks. That will suffocate the lice. She also says while lice are a nuisance, they do not cause serious health issues. For Medical Edge, I'm Vivian Williams.
Okay, benign tumors are growths on the skin that do not metastasize. Remember that metastasis is the ability of a mass to spread to distant areas of the body through the movement of cells away from the initial site of growth to populating other tissues. And this is a hallmark of malignant cancer. It's one of the ways that we actually stage the disease. But some benign tumors of the skin include seborrheic keratoses. These are benign growths that originate in the epidermis. Dermatofibroma, which are benign asymptomatic growths, can be found anywhere on the body, and acrocoordon, which are skin tags. These are common benign skin growths that are found mainly on the axilla, the neck, and the inguinal areas of the body. A sudden increase in the number of seborrheic keratoses could indicate the presence of an internal malignancy, often in the stomach, the gastric region. The types of reactions that are thought to cause dermatofibroma are fibrous reactions to viral infections, insect bites, and or trauma. There are other types of tumors that we would classify as pre-malignant. These are skin growths that, if they're allowed to go further, could become malignancies. Actinic keratoses are common pre-malignant lesions that are found on sun-exposed areas of the body. Cause is UV light. This is the agent of DNA mutation in skin cancer because UV light can alter the structure of DNA, causing the double helix itself to buckle. And then when the cellular apparatus attempts to repair this buckle, often it can make an error, and this can produce a mutation in a gene that controls the cell cycle, and the cell can then go off on its own cell division schedule, irrespective of what the body signals are telling that particular tissue to do. Indications are an area of rough vascular skin, which can later form a yellow crust. The people that are at highest risk are light-skinned people. The reason is they lack melanin, and melanin is one of the things that we use to block UV radiation on the skin. The differences between benign and premalignant tumors, seborrheic keratoses can be treated with cryosurgery and curettage. Dermatofibromas can be surgically excised if they're symptomatic. Keratocanthoma is treated by a surgical excision, use of adrenocorticosteroids applied topically, and for multiple lesions, oral isotretinoin and etretinate administration. That's etretinate. Etretinate. Keloids and hypertrophic scars are treated with corticosteroids injected into the lesion once every 4 weeks or surgery with scar compression. Epidermal or sebaceous cysts are excised surgically and treated with antibiotics if necessary, and skin tags are also treated with excisional surgery. Finally, actinic keratoses are treated with topical agents such as T-retinoin, or also known as retin A, all by itself or in combination with fluorouracil, and by curettage and desiccation. For those that don't know, desiccation means to dry out the offending mass and cause it to die. Okay, other skin carcinomas are non-melanoma skin cancers such as basal cell carcinoma or BCC, squamous cell carcinoma or SCC. Malignant melanomas are follow a series of morphological changes that we can use to identify the transition from a benign mass to a malignant mass, and so we typically use the ABC system to determine whether or not we have a mass that could potentially become malignant. Actually, ABCD system. A is asymmetry, B is border, C is color, and D is diameter. The most prevalent form of cancer worldwide is basal cell carcinoma. Why are basal cell carcinoma and squamous cell carcinoma usually not included in most cancer registries? And the reason is they don't generally metastasize, so these particular conditions tend to stay benign. The relation of epidermal melanocytes and malignant melanoma are that they are the source of malignant melanoma. So you start with an epidermal melanocyte and then it can become a malignant melanoma. This is one of the reasons that the physician will tell you to periodically check your skin for changes such as those indicated by the ABCD acronym to a mole or a skin tag. The idea here being that these changes could be early indicators of a transformation from benign tissue mass to a malignancy. So how do we protect ourselves from the UV rays of the sun? We can avoid exposure between 10 a.m. and 3 p.m., plan our outdoor activities for early morning or late afternoon, and wear protective clothing. Also, the use of sunscreen is recommended. What's the single most important piece of protective clothing that'll help us guard against sun exposure? That would be the use of a hat with a brim. What is the minimum sun protection factor that should be used? And that would be 15. To aid in early detection of skin carcinomas, we should perform regular skin self-examinations. People at high risk, such as those with a family history, multiple atypical or common moles, or excessive sun exposure, should see their physician for periodic whole-body exams and look for early melanoma lesions. So let's take a listen now to skin cancer.
Skin cancer is a disease in which malignant cells are found in the epidermis. The epidermis contains 3 kinds of cells: flat, scaly cells on the surface called squamous cells, round cells called basal cells, and cells called melanocytes, which give the skin its color. The most common types of skin cancer are basal cell cancer and squamous cell cancer. Skin cancer is more common in persons with light-colored skin who have spent a lot of time in the sunlight. Skin cancer can occur anywhere on the body, but it is most common in places that have been exposed to more sunlight, such as the face, neck, hands, and arms. The most common sign of skin cancer is a change on the skin, such as a growth or a sore that will not heal. Sometimes there may be a small lump. This lump can be smooth, shiny, and waxy-looking, or it can be red or reddish-brown. Skin cancer may also appear as a flat red spot that is rough or scaly. Cancer that develops in the pigment cells is called melanoma. It usually occurs in adults, but may occasionally be found in children and adolescents. Melanoma strikes more than 50,000 Americans annually and causes an estimated 7,800 deaths. Often, the first sign of melanoma is change in the size, shape, or color of a mole. Scientists have pinpointed a genetic marker that may serve as an early indicator for melanoma. This is very important because the disease is curable if caught early, but is usually fatal if it is not.
Okay, some abnormal skin pigmentation conditions include albinism, which is an inherited inability to produce melanin. So these individuals are extremely light-skinned, and it's recommended that they spend limited amounts of time in the sun in order to avoid conditions such as skin cancer. Vitiligo, which is pale, irregular patches that can indicate an immune system disorder. Melasma or chloasma, which are patches of dark skin on the face. Hemangiomas, which are benign lesions of highly vascularized skin, which may be flat, such as in the port wine stain, elevated or protuberant, meaning that they stick out from the surface of the skin. Where does melasma often occur? In pregnant women or in women using oral contraceptives. In which part of the body are port wine stains generally found? Generally on the face, and moles are primarily composed of dense collections of melanocytes. And most of these are not anything to be alarmed about. They're primarily cosmetic problems and can be treated under the aegis of cosmetic surgery. But if left alone, it's not going to really significantly impact your quality of life. Nevi or moles are a congenital or acquired highly pigmented area on the skin that is either flat or raised. Excuse me. Nevus would be the plural of this particular term. And pityriasis are fungal infections that cause patches of flaky light or dark skin on the trunk, while an abnormal suntan is characterized by an unusual darkening of the skin that results from properly used medications. The treatment for moles is generally surgical resection if necessary. A variety of these conditions, as I indicated, can be treated with cosmetic surgery. So let's take a listen to a little video on benign versus malignant skin lesions.
Okay, hold on and I'll put some on you too.
Before Amber Holly lets her kids go out and play, they slather on a handful of sunscreen. As a kid, Amber never did and has had 28 moles removed from her skin, and 6 found on her back proved to be cancerous.
I should have had them taken off before, but I just didn't think nothing of it. I can't see them if they're changing colors because they were on my back.
Which is exactly how so many skin cancer patients get into trouble.
Let's take a look at your ear.
Doctors say the neck, back, and scalp can be danger zones where cancerous moles often go unnoticed.
You should really be looking everywhere. If you have a significant other, have that significant other check you from top to bottom, front to back.
Dr. Maria Risa Conroy with the Ohio State University Medical Center says if you do find a suspicious mole, keep 5 letters in mind: A, B, C, D, and D. A stands for asymmetry. What shape does the mole have?
The moles that tend to be malignant are irregular in shape. The ones that are benign are rounded.
B stands for border. If the mole has a rough edge, get it checked. Color is also important. Moles with more than one color could spell trouble. So could those with a larger diameter. Moles larger than a pencil eraser should be checked. And E stands for evolution.
Evolution meaning there's a change in either the shape, the size, the color, or sometimes symptoms like bleeding.
That's what caught Amber's eye. Blood on her shirt made her realize she had moles on her back and that she needed to look for them more aggressively. At Ohio State University Medical Center, this is Clark Powell reporting.
Okay, alopecia, or male pattern baldness, is hereditary. It's what's termed a sex-influenced trait. So that means that the X chromosome carries genes that can affect the expression of this particular phenotype, this physical manifestation of what's on the genetic material. It can also be accelerated by the aging process and can be the result of either systemic illness or dermatitis. If a man wants to know what his hairline is going to look like, all he needs to do is look at his maternal grandfather, and that's going to be an indicator of which X chromosome he's going to receive as a result of the normal passage of genetic material in heredity. Remember that men have one X chromosome and one Y chromosome, and that the Y chromosome basically has no counterbalancing genetic information to mask what's on the X, so anything that shows up on the X that's related to characteristics other than sexual identity are going to be expressed. The types of systemic illness that can cause baldness are thyroid disease, iron deficiency anemia, syphilis, or certain autoimmune disorders. Also, certain forms of dermatitis can cause alopecia as well. There are drugs that have been introduced recently to prevent baldness. Examples are Rogaine and Propecia, and also the very recent technology called hair cloning, where what they can do is take the cells from the hair follicle and culture them and then reimplant them in follicles that have quit producing a hair shaft and cause natural hair to regrow from the head. This last option is extremely expensive and not a practical solution for men who are not covered by something like insurance to deal with something like alopecia. And obviously most insurance plans are not going to cover such treatment. That would fall under the umbrella of cosmetic treatments. So let's take a little listen to alopecia.
Male pattern baldness is a genetic condition. You get some genes from your mum's side, some from your dad's side, but you do need genes for balding. It's nothing to do with the fact that you didn't look after your hair properly, or you wore a hat, or you didn't wear a hat, or you used the wrong type of shampoo. You have to have a genetic component to baldness. And you also have to have the male hormone testosterone. And the male hormone is broken down into something called dihydrotestosterone. And if you have the genes for baldness, it's the dihydrotestosterone that affects those hair genes and makes your hair fall out. And for some reason it affects the hair on the top and the front of your head, but not on the sides and the back of your head.
Okay. Verrucae or warts are elevated growths of epidermis that result from hyperplasia. These are often caused by viral infections, which produce benign overgrowth of the skin. Deformed or discolored nails are any unusual thickening, color variation, or change in shape of the fingernails or the toenails. The most common type of wart are those that occur on the hands or on the soles of the feet. If they occur on the soles of the feet, they are called plantar warts, and instead of protruding from the skin, they grow into the skin, and this causes obviously pain and pressure. They're spread by touch or contact with the skin that is shed from a wart because it contains active virus particles. Some of the diseases that can cause deformed or discolored nails are poor circulation, lichen planus, which is basically toenail fungus, chronic bronchia, iron deficiency anemia, chronic hepatic disease, infection of the cardiac valves, systemic lupus erythematosus, and dermatomyositis. Nails damaged by injury generally grow back in 9 months. Another thing I want to point out with regard to the wart is that the treatments are generally topical acids that will eat away at the benign growth, and the idea is that you want to erode away enough of the overgrowth that you can outrun the virus. In the event that this treatment doesn't work, you can use cryosurgery or laser surgery to have the wart excised, and generally when this is the method of choice, we remove some skin that's going to be healthy in an effort to keep the virus from infecting any further areas around the particular lesion. Now, you might wonder, well, where do these pathogens come from? The pathogen that causes warts is all around us. It's in the air that we breathe, the water we drink, and the food that we eat. And it's on the soil under our feet. So why doesn't everyone have plantar warts and warts all over their body? And the answer again is genetics. It's your genes that determine primarily whether or not your skin is going to be a fertile ground for infection by the agent that causes warts and the subsequent overgrowth that you experience. So just as we discussed with regard to stomach ulcers that are caused by that bacteria, Helicobacter pylori, you have to have the right tissue type in order for the pathogen to make a home and to begin to generate the particular disease, in this case the skin lesion. So with that said, hopefully I'm going to be back with y'all next week. I anticipate definitely I would be back. Have a wonderful rest of the week, and make sure and complete the take-home exam, and I'll pick that up next Wednesday. Be sure to hand in your assignments to Georgina from last week, and I'll talk to you later.